This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello, everyone. This is Andy Sutherland from the University of Virginia. And for this week's Neurology podcast, I have the pleasure of speaking with Hassan Kabesi and Alejandro Robinstein from the Mayo Clinic. We're going to be discussing an article published in this week's issue of Neurology titled Computed Tomography Perfusion versus Non-Contrast Computed Tomography for Late Window Stroke Thrombectomy, a systematic review and meta-analysis. In this study, Hassan and Alejandro and their co-authors performed a review and meta-analysis of studies looking at late window, otherwise known as time window of 6 to 24 hours from last known well, for endovascular stroke therapy for large vessel occlusion, acute ischemic stroke, and specifically looked at studies comparing patients who received CT perfusion imaging or multimodal CT perfusion imaging versus non-contrast head CT or CT angiogram to determine treatment eligibility. The method and availability of head imaging prior to endovascular stroke therapy for those who practice stroke and for those who don't has been a topic of increasing interest in the field. There have been some recent trials and publications suggesting that patients may benefit regardless of the degree of infarcted tissue prior to treatment. And so the nature of the type of imaging that we do and that we require prior to treatment is on everyone's mind. So this is a timely article. And Hassan, Alejandro, thank you for joining us for the podcast.
Our pleasure.
Thank you for having us.
And then Hassan, I think this first question is for you, just to kind of summarize from the get-go for the audience. What were the major findings from this review and meta-analysis that you all did?
We performed a systematic review and meta-analysis of large vessel occlusion stroke in the late window, which is 6 to 24 hours. And we ultimately ended up including 5 studies with 3,384 patients. And in these studies, patients were imaged with either CT perfusion imaging or non-contrast CT to determine eligibility for endovascular intervention. What we found is that for our primary outcome of functional independence, patients that were selected with CT perfusion and non-contrast CT actually achieved functional independence at similar rates. For our secondary outcomes, we found similarly that symptomatic intracranial hemorrhage was comparable between the two imaging modalities. However, we found that patients imaged with CT perfusion achieved a higher rate of successful reperfusion, and similarly, they achieved a lower rate of mortality. So overall, we found that the primary outcome was similar between patients that were selected with CT perfusion and non-contrast CT. We found that patients selected with CT perfusion actually achieved higher rates of successful reperfusion and lower rates of mortality. Now, we also extracted the baseline characteristics of patients included in our 5 studies, and we found that the frequency of male sex and female sex was similar between the two groups. The amount of patients that received intravenous thrombolysis was similar between the two groups, and the baseline stroke severity was similar between the two groups. Now, of note, patients that were imaged with CT perfusion actually had a greater onset to puncture time by 45.6 minutes. And this was the only baseline difference that we found between the two imaging modalities for selecting patients.
Well, I guess to that last point, Hassan, that's probably not to be unexpected that the folks receiving the CT perfusion imaging would require more time, have a longer aortic growing puncture time for their endovascular treatment, which you all discussed in the paper, of course. But as you noted, ultimately didn't lead to any differences between the two groups in functional outcome. We're going to talk about the larger implications of these results here in a moment. But before that, anytime one does a retrospective review of studies or meta-analysis, there are always possible sources of bias or issues with generalizability. Did you encounter many of those in the studies you ultimately analyzed? And how did you attempt to mitigate any source of bias?
We actually did encounter some sources of bias, as you alluded to. The chief limitation of our meta-analysis was that we were only able to include 5 studies. Now, the reason we were only able to include 5 studies is because we specifically only included studies that imaged patients with both CT perfusion and non-contrast CT. We did not want to have single-arm studies because that would introduce too much bias to our analysis. Due to the low number of studies, we were unable to perform meta-regression, and therefore we could not test for the effect of individual confounders. Similarly, we did not have access to patient-level data, which also limited our ability to test for certain confounders. Now, something specific to our study and the studies included was that the aspects, which is a measure of the severity of the stroke and the size of the core, was high in our study, meaning that the patients had less affected tissue and smaller cores. The median aspects of studies included in our study was 8. So this could have actually limited the difference in treatment effect, and for future studies, it may be a point of interest to see if they can include patients with lower aspects and larger ischemic cores. A couple other limitations that we had was that one study reported functional independence at a different time than the other studies. 4 studies reported it at 90 days, and one study reported it at 6 months. And one other thing was that we were unable to account for single phase and multi-phase CT angiography due to inconsistent reporting among the included studies. Now, in order to mitigate these biases, we only included comparative studies, as I mentioned. Every study that we included was deemed to be of high quality and had a low risk of bias, and they were all multi-center studies. Finally, all 5 studies provided all 4 of our outcomes of interest, so we were able to have a decently large sample size of patients.
No, Hassan, I think clearly, having read the article and hopefully, we'll encourage our listeners to as well. I think it's a very sophisticated analysis, and you all did a great job of trying to make sure that there was a high quality to the data that went into the analysis, and your methods were sound to try to account for some of those issues. One thing for our audience, again, many of whom may not practice, acute stroke therapy on a day in, day out basis, the aspect score that you mentioned, which is sort of a score that we use to estimate the degree of infarction or early ischemia on a head CT, did suggest that these were folks that likely had salvageable penumbra in both groups. And so I think that is an important point you make, particularly as with my introduction mentioning some of the trials looking at people with more evidence of early ischemia or infarction prior to treatment. I think that'd be an important group to account for in future analyses, as you've already rightly noted. So let me turn it to your colleague, Alejandro here. So the question on everyone's mind, of course, after this study and with our accumulating data is what should we be recommending for pre-treatment imaging for patients undergoing endovascular therapy for large vessel occlusion stroke? I'm obviously curious what you all are doing and how you may be advising your partner hospitals, particularly those smaller hospitals that are less resourced with the rapid availability of imaging.
This meta-analysis gives us the state of literature on this topic. But one of the things that it points out is that we only have information from registries, some retrospective studies. We do not have a randomized controlled trial comparing the selection of patients for endovascular therapy using only non-contrast CT or CT and CT angiogram versus using CT perfusion. And the trials were conducted on the extended window, this window between 6 and 24 hours since the patient was last known well, included perfusion scans as part of the eligibility criteria. And primarily because that is the way that endovascular therapy was validated to be useful in this time window for these patients with large vessel occlusion, is that we still use, in most cases, we still use CT perfusion. Now, going back in time, I'm sure, Andy, you remember that the idea of CT perfusion was mostly to identify patients who might be at risk for reperfusion injury, hemorrhage, and so forth, if they were recanalized, despite the fact that they were having already large established strokes. Well, based on the results of our meta-analysis, where the functional outcomes were comparable, where the hemorrhage rate was also comparable, that original intention of CT perfusion does not seem to pan out. Similarly, now we have information from large core trials, even very late time windows, where again, there seems to be a little bit more safety than we initially thought. And so I think that is the main message. Even if you do not have CT perfusion, if you take a good look at your CT, if you have the CTA, you take a good look at the CTA. In centers who have less technological resources, yet they have the ability to either perform or triage patients to endovascular therapy. Doing it with the non-contrast CT would be a valid, in all likelihood, safe alternative, even if it may result in some patients having futile treatment. Because what the CTP will give you is information on salvageable tissue. In our meta-analysis, identify more patients that were able to be successfully reperfused. So in summary, we still tend to use CT perfusion in the 6 to 24-hour window and beyond, but we serve a large community where patients go initially to small centers, and that first selection of, yes, this patient needs to come, we do it with the CT and the CTA. And depending on the case, sometimes we do a CT perfusion on arrival to our hospital before going to the angio suite. Personally, many times I am bypassing that and I'm going directly from the helicopter to the angio suite without obtaining the CT perfusion in between, if I am already convinced based on the clinical information and the radiological information from the CT and the CTA that I think that the patient is a good candidate for endovascular therapy.
Thank you, Alejandro. I think that's very helpful and a good framework, I think, that folks can think about depending on which setting and which aspect of that continuum that they're practicing in. And in most situations, I think we all know inherently that it all depends on the exact relationship between the initial hospital and the ultimate endovascular treatment center or thrombectomy capable center the patient goes to, about the method of imaging and transfer, all with the attempt to expedite treatment. So before we wrap up, as you think about this, what are the remaining gaps? Where does the research taking us? And then any final thoughts you want to share with the audience?
Like with so many other things, ideally, we are going to end up having a randomized control trial comparing candidacy based on CT versus CT perfusion. There is also a whole move using better technology and artificial intelligence to get more out of the plain CT, at least promises to change the way that we use imaging for the evaluation of acute stroke. There may be a day when just getting a CT gives you a wealth of information that already tells you, just with the CT, where there is a large vessel occlusion, how much of an established infarction there is, how much of the salvageable tissue there is, what are the chances even of successful reperfusion, all from the CT. That is perfectly within the realm of imagination at this point, but obviously still something that is a promise that remains to be fulfilled. So at this point, I think that practices, as you well mentioned, need to be adjusted to the local availability of resources. The intention should always be to try to recanalize and reperfuse patients with large vessel occlusions unless there is a clear contraindication because of the powerful beneficial effect of this treatment intervention.
Well, fantastic. Thank you, Alejandro, for those guiding thoughts. And CTP or not to CTP, that remains the question. But I think we're further along in our understanding than we have been, in large part. Thank you to you all for performing this analysis, which I think is helping move the field forward. So again, this has been Andy Sutherland speaking with colleagues, Hassan Kabesi and Alejandro Robinstein from Mayo Clinic. And I want to encourage all of our listeners, please seek out the full paper published in this week's issue of Neurology, Computed Tomography Perfusion versus Non-Contrast Computed Tomography for Late Window Stroke Thrombectomy, a Systematic Review and Meta-Analysis. Gentlemen, thanks again for joining us for the podcast.
It's been a pleasure.
Thank you for having us.
This is Stacey Clardy, your podcast editor. Thank you for listening and for letting us join you on your commute, while you're exercising, or even while you're brushing your teeth. This has been another episode of the Neurology Podcast, your best source of practical, relevant, and timely information for neurologists, clinicians, and patients.